So this was my gram rounds topic back in September, and we titled it A Ring of Controversy. So the patient presented for a second opinion cornea evaluation to one of our cornea attendings. He was a 54-year-old white male who had worn contact lenses since high school. He had been in a hybrid contact lens for about 6 to 7 years and was complaining of foreign body sensation and irritation in his left eye for approximately 2 months. He had been seen by his optometrist, who noted some kind of nonspecific corneal changes and suggested that he stay out of his contacts. They had tried, he had seen the optometrist a couple visits. They've tried antibiotic drops, antiviral drops, and when he came for his second opinion corneal evaluation, he was on Lotemax, BID, and preservative-free artificial tears. He had already seen another cornea specialist who diagnosed him with limbal stem cell deficiency and had recommended that the patient see Dr. Holland in Cincinnati, who does limbal stem cell transplants. So physical exam, the patient's right eye was 20/40. In the left eye, he pinholed to 2400. His pressure in the affected left eye was 35. His pupils were equal, extraocular motility was full. He had superior neovascularization of the cornea in both eyes, and in the left eye also had 3+ conjunctival injection, this diffuse lackluster epithelium, and central PEE. So here are some representative photos of what his left eye looked like. You can see the superior neovascularization on the external photo, and with fluorescein, this kind of just lackluster epithelium. So he was diagnosed with limbal stem cell deficiency, secondary to long-term contact lens use that was worse in the left eye than the right. There were no signs of infection at the current visit. He had an appointment with Dr. Holland in 3 weeks, and we told him to kind of keep that follow-up. We did recommend changing the Lotemax gel to preservative-free dexamethasone, and we're going to treat his elevated IOP with Diamox orally as to not add any further eye drops for the epithelium. For comfort, we recommended to see the optometrist for a scleral contact lens in the left eye and to stay out of contact lenses in the right eye. 1 week later, his pain was progressively worsening. He had seen the optometrist for that scleral contact lens evaluation, and the optometrist stated that the cornea looked much worse. So the contact lens eval was aborted, and the patient was seen in the cornea specialist's office the same day. His visual acuity was about the same, 2200. His pressure was 28, and he now had 3 to 4+ conjunctival injection, diffuse neovascularization of the cornea with ulcerations superiorly and inferiorly, and scattered KP. So now he's been diagnosed with a keratitis in the left eye in the setting of limbal stem cell deficiency, and a Procara was placed in the office, and he was scheduled for a corneal biopsy and amniotic membrane transplantation in the OR the same week. So 2 days later, the corneal biopsy procedure was performed. The first part is not sterile. We used a 2mm derm punch to perform partial trephination of the ulcerated and non-ulcerated specimen. A crescent blade was then used to dissect off the specimen that was sent in formalin to pathology. And we're thinking something strange is going on here. Is there a fungal infection? Could this be acanthamoeba? And then we also did a full set of plated cultures just to be complete. Then the sterile part of the procedure was performed, in which amniotic membrane was sutured down over the cornea with a contour contact lens placed over the graft. The patient was placed on Vigamox 4 times a day in the left eye. So day 1 post-op, he was seen in the office. Visual acuity, of course, is not great. He's got a Procara in place over the amniotic membrane. His pressure's 25, and we're waiting for the cultures and biopsy results to come back. So we kept him on the Vigamox 4 times a day. We're holding steroids. He's wearing a shield at night, and he's supposed to come back in about 5 days. On post-op day 4, the path results returned, and the patient was diagnosed with acanthamoeba keratitis. The microscopic description stated there were many stromal acanthamoeba cysts of about 8 to 13 microns in diameter, with prominent nucleoli and cyst wall, and a paucity of inflammation that is typical of acanthamoeba. So you can see the surgical pathology results here. On low power, you see these cysts with very little other inflammatory cells surrounding it. And it's just an easier view of the high-powered kind of double-walled cysts that are characteristic of acanthamoeba. So the amniotic membrane graft and the contour were removed. He had a ring infiltrate now with inferior KP. His epithelium was intact, and the biopsy site was noted superior temporal. He was started on PHMB drops and dexamethasone every hour while awake on alternating days, as well as the Vigamox continued twice a day, ketoconazole orally, and Norco PRN for his pain. So 1 week after the biopsy and AMG, he had some improvement in his pain, no real change in his vision, and the cornea had an almost complete epithelial defect with endothelial debris inferiorly. He had 1+ cell of his anterior chamber, really kind of minimal improvement, and we were just going to kind of continue the course. So this is a short kind of talk here on Acanthamoeba keratitis. It's a free-living ubiquitous protozoa that's found in freshwater and soil. It's resistant to killing by freezing, desiccation, and routine levels of chlorine. There are two forms, the motile trophozoite form and the dormant cyst form. The initial corneal adherence is mediated by mannose-binding protein, with subsequent stromal invasion that's promoted by the expression of mannose-induced protein and various collagenases. Risk factors: about 90% of Acanthamoeba keratitis in Western countries is due to contact lens wear. Ocular trauma, swimming, hot tubs, showering, especially while wearing the contact lens, and contaminated water sources. The clinical presentation is usually severe ocular pain, kind of out of proportion to your clinical findings, photophobia, injection, decreased vision, this protracted kind of progressive course, and frequently no therapeutic response to a variety of topical antimicrobial agents. It's localized to the corneal epithelium early on and could present as just diffuse PEE or dendritic epithelial lesions. The stromal infection is typically centrally with gray-white superficial, non-suppurative infiltrate. As the course progresses, you can see a partial or complete ring infiltrate. Radial perineuritis is pathognomonic for Acanthamoeba keratitis. So the diagnosis is made by visualizing the amoeba in stained smears or by culturing organisms obtained from corneal scrapings and biopsy. The culture yield is lab dependent, and unfortunately, reportedly, it's only about 35 to 50% positivity. Smears are stained with Giemsa, PAS, calcifluor white, acridine orange. The preferred medium is non-nutrient agar with E. coli. The characteristic trails will form as these motile trophozoites travel across the plate surface. Treatment: there's a variety of treatments: diamidines, biguanides. Biguanides are the mainstay of treatment because they're the only ones shown to have an effect on both forms. Some people try aminoglycosides, these oral azoles, and steroid treatment has not really been shown to improve or worsen outcome. Therapeutic keratoplasty is typically reserved for vision rehab after treatment has been completed or for continued progression despite maximum medical treatment if after 3 to 6 months of treatment and disease-free is the best. So I left in the study here about penetrating keratoplasty for the treatment of Acanthamoeba keratitis. You'll see that a microbiological cure was achieved in all surgical cases. Among the therapeutic KPIs, 1 keratoplasty was required in 14 eyes, 2 in 6 eyes, and 3 keratoplasties in 2 eyes. After the initial keratoplasty, survivals after TKP are listed here at 1, 5, and 10 years respectively. The median visual acuity was 20/40 after therapeutic KP and 20/25 after an optical KP. So TKP can successfully treat medically unresponsive cases of Acanthamoeba keratitis, although multiple grafts may be required and the visual prognosis is guarded. Optical keratoplasty performed after resolution of the active keratitis is associated with a better prognosis for both graft survival and visual outcome. So Acanthamoeba keratitis is important because there's this substantial delay from symptom onset to diagnosis of Acanthamoeba keratitis, and this is why it's associated with poor clinical outcomes. So Chow et al. Noted that most cases were classified already as advanced stage at their initial presentation and kind of delineated this early stage and how they treat early versus advanced versus late.
So this is a case of a 63-year-old female who initially presented to an outside ophthalmologist for evaluation of a growth inside her right lower eyelid back in June of 2015. At the time, on exam, she was noted to have multiple papillomatous vascular growth with confluent pigmentation over the entire palpebral conjunctiva of her right eye. Because the patient was asymptomatic at the time, the recommendation was to reevaluate the patient in 6 weeks. The patient did follow up approximately 6 weeks later. At that time, again, she was noted to be asymptomatic, exam unchanged, and therefore the recommendation was to reevaluate the patient in 3 months. However, the patient presented to an outside ER not too long thereafter with a complaint of foreign body sensation and a red right eye. She was discharged home on a prescription of erythromycin ointment. She was seen here by one of our cornea attending upon referral for this growth inside her right lower eyelid. Review of her past ocular history showed that patient had cataract surgery in both eyes as well as a PRK in the left eye. Past medical history significant for hypertension as well as a history of cervical cancer. Past surgical history noted a history of complete hysterectomy. Family history was non-contributory. Social history noted that she was a former smoker and only occasionally drinks. She has no known drug allergies and her medications are as listed. So her physical exam, visual acuity without correction, right eye was 20/50, left eye was 20/25. Pupils were equal and reactive to light. There was no APD detected on exam. Eye pressure 15 in the right, 14 in the left. Her extraocular movements were intact. On anterior segment exam, there was a large papillomatous lesion with pigments in the right inferior conjunctival of the right eye, and the remainder of her exam was normal. This is a picture of her right eye. As you can see, there is an extensive, large papillomatous lesion extending over almost the entire lower palpebral conch. And so these were the differential diagnoses that were considered, with the biggest concern being that this could most likely be a conjunctival neoplasm. And so the recommendation was to start the patient on interferon 4 times a day in the right eye to debulk the lesion, and she was subsequently scheduled for a biopsy. In the OR, the lesion was extensive, very large, therefore an excisional biopsy was not possible, and instead an incisional biopsy was obtained for diagnosis. The surgical pathology returned, noting that this was an invasive carcinoma with both squamous and sebaceous differentiation. Of note, it was felt that the lesion has significantly changed, enlarged at the time compared to her exam 1 month prior, and so a CT orbit was obtained. The CT orbit showed that there was a right intraorbital mass measuring about 1.9 by 1.8 by 0.9 centimeter abutting the globe and extending to the right inferior rectus, but there was no bulky invasion of the globe itself. And so when this case was initially presented at Grand Round back in December, the question that we posed to our audience was, what was the next best thing to do for this patient? And the overwhelming response was that we needed to seek a second opinion. We reached out to Dr. Carol Shield, a renowned specialist on ocular oncology, and her advice to us was to seek a second opinion on the pathology. As you would recall, the initial pathology noted that this carcinoma had both squamous and sebaceous differentiation. And so she stated that if the second pathology opinion was supportive of a squamous cell carcinoma diagnosis, then there were 2 treatment options for the patient. The first option would be to proceed with an examination, and the second option would to do weekly injection of interferon for 8 weeks, then re-image the patient, and if the lesion has decreased in size, then possible resection of the residua, and hopefully avoid an examination in the patient. If the second pathology opinion supported a sebaceous cell carcinoma, then the only option would be to proceed with an examination. And so that's what we did. We sent the biopsy to Will's eye, and the report was that this was a poorly differentiated carcinoma, probably squamous cell carcinoma. She was referred to the oculoplastic service here at UAB, in which patient was evaluated and subsequently had an examination. The final pathology from the Mayo Clinic noted that this was an invasive, moderately differentiated squamous cell carcinoma, and that the margin of resection was free of involvement. On follow-up, she received oculoplastic in February of this year. At that time, she was healing well from the examination. However, a mild lymph node was detected at the angle of her right jaw, concerning for possible spread of the squamous cell carcinoma. The patient was referred back to her private doctor back in Florida, at which time she underwent a head neck dissection and now has planned to undergo chemoradiation. So this was a very unfortunate case for our patient. However, it highlights some great learning points for doctors, residents, and training. And one of the teaching points is that you have to have, a high suspicion as well as, early recognition for possible malignant features. Some of those malignant features of concha tumor could be a raised lesion, pigmentation, which was repeatedly documented on her exam over several visits. Other features would be vascularities. And then the last is that there was a need for biopsy for definitive